Hi everyone, my name is Harrison Steins, and I am here to talk about critical care echocardiography, or at least the way I think about performing a more comprehensive cardiac focused exam with ultrasound. A bit of background about me. I am currently a fourth year medical student. I'm interested in emergency medicine and austere medicine and wilderness or resource limited medicine and how we can apply ways we perform actions in the hospital in environments without the necessarily correct tools or without the abundance of tools that we see them in the hospital with. I'm also a master's candidate for the College of Remote and Offshore Medicine in austere and austere critical care. At my medical school, I'm a predoctoral clinical ultrasound scholar. So I'm in the inaugural class of people who've really liked ultrasound and want to see it progressing in medical education. So I'm making this lecture because I've gotten to the point, and I know many of my colleagues have, in medical school at least, as well as people I've worked with in EMS and pre-hospital care, whether it be from the flight side or the ground-based transport side, or some military colleagues. We've gotten to the point where we have exhausted the ultrasound knowledge with FAST, with brush, with AAA screening, IVC, checking for volume status of patients. And I thought, with my probe already on the chest, I'd love to know more. But I think that the overwhelming amount of information around echocardiography and what, as maybe emergency medicine providers, and obviously I'm not an emergency medicine physician yet, but I hope to be, but what we can pull from that in kind of the basic exams that med students learn and pre-hospital providers learn is exhausted, right? So I'd love a more comprehensive way about going at looking at the heart without necessarily having the experience or knowledge of a cardiologist or an intensivist in the ICU that's looking at these advanced exams. So I went through the literature, I went through countless videos, spoke with many physicians, and kind of looked through all the information out there and developed my own lecture on a condensed version of echocardiography for a emergency medicine critical care provider. And in effort to expand my knowledge base, I wanted to record this lecture so I could help anyone else looking for the same. So what we're going to do today is go through an introduction into the five major cardiac windows and the views of the heart. That will include the IVC, subcostal view. We're going to talk a little bit about performing proper cardiac ultrasound technique, evaluate and how we're going to evaluate for major cardiac ultrasound pathology, spending a bit of time looking at evaluation of left ventricular ejection fraction and how ejection fraction plays into our understanding of pathology, and then estimating central venous pressure for fluid status, fluid tolerance using the IVC, which if you've done the rush exam or things like that, you've most undoubtedly learned already. So our exam overview, the first thing to note is that multiple views are obtained in each window. So some parameters, like the measurements we'll be taking of the left ventricular diameter, can be evaluated in several different views in order to assess the reliability and reproducibility of these measurements. Starting off with positioning, we're going to look at the parasternal long axis view, the parasternal short axis view. Then moving into the apical views, we'll do the apical 4-chamber, 5-chamber, and 2-chamber view. You can look at other multi-chamber views of the heart, but in my research, I kind of decided to focus on these. And then coronary sinus view, subcostal view, subxiphoid, and IVC view. Important to note patient positioning. The parasternal and apical windows are obtained with the patient in the left lateral decubitus position. That is, if they can actually get into this position. And then the subcostal suprasternal windows are obtained with the patient in the supine position. So moving on to a note on measurements. The chamber measurements constitute key parameters of each of these exams. So we'll be looking at anterior-posterior measurements, looking at measurements from internal to internal, external to external parts of the muscle, or parts of valves. It's important to note exactly where these measurements are starting to come from so that they're standardized across both the measurements that we're using to determine pathology or normal, as well as being able to communicate all of our findings effectively. So the ventricular measurements made using the electronic calipers on the ultrasound machine are measured with the tips positioned the interface between the compacted myocardium and the non-compacted myocardium, the trabeculae. So the bundles of muscles that are projecting from the inner surface of the ventricle of the heart. And they're kind of like sponge-like network muscles used to provide support to the heart. That's where we'll be taking one of our measurements to the compacted part. So the non-sponge-like, non-trabeculae part of the myocardium. So other dimensions, including the atrial dimensions, the mitral annulus, aortic annulus, and a couple others that we're going to mention, are measured using the blood tissue interface. So this is the inner edge to the inner edge. These are important because if you obviously these measurements can be small, so if you are measuring inner edge to outer edge, you're not in line with kind of best standard practice, and you're not actually getting the real measurement. But two, you could call something pathologic or non-pathologic when it actually is. So moving straight into our parasternal long axis view. This is a view that's going to be showing mostly the left side of the heart, leaving that right ventricle, right atrium out of our main view. We'll be looking at the left ventricular outflow tract, let me see if I can turn on, oh, here, perfect. So we're going to be looking at kind of starting in, we'll actually go through like left atrium, coming into left ventricle with mitral valve, coming into left ventricular outflow tract and the aortic valve. We want to be able to see a little bit of the right ventricular inflow tract up here into part of the right ventricle, but that's not the focus of this exam. What we're looking at is really, are the structures well defined? Are there vegetations that we can see? So anomalies of bacterial growth, of evidence of something like endocarditis. I want to see that the movements are uniform. So looking at something like the mitral valve, are both the leaflets co-opting, aka coming together fully? Is one coming together more? And then are the muscles of the ventricles of the atria closing in and opening up in systole and diastole in uniform size relative to the time in the cycle and relative to the other structures. So say looking at collapsibility of the, or not collapsibility, but closure in systole and diastole of the left ventricle compared to the right ventricle, looking at the interventricular septum, which is right up here, to see, is it bowing one way or the other or something like that. So once we've taken that parasternal long axis view, this initial bit of information into structure of the left ventricle, left atria, and the rest of these structures on here. So next we're looking at the left ventricular outflow tract, and here we're going to be taking a measurement using the calipers on the ultrasound. So the left ventricular outflow tract is a critical measurement to understanding aortic stenosis. So if we remember the aortic valve closure by cooptation, where the valve leaflets come together, happens during ventricular diastole. So as the heart's filling, you don't want anything to be spilling out into the aorta. And in systole, the systolic wave of pressure from the heart contracting can dilate the region, opening up those leaflets. So we utilize the diameter of the left ventricular outflow tract at the end of systole, and so systole where everything is dilated, as a reliable estimation for aortic valve area, and from that we can conclude whether or not there's aortic stenosis. So this measurement's really important as to where we take the measurement. You can see kind of the purple line right there would be the measurement of where your calipers would be, and it's measured near the aortic annulus at the base of the leaflets. A trick that I was looking up was that the aortic annulus and left ventricular outflow tract are measured in mid-systole and inner edge to inner edge. So everything on the aortic side of the annulus is then measured in end diastole and leading edge to leading edge. So there's historical precedent behind this based on the progression of ultrasound and where people were taking measurements. It was thought to take inner edge to inner edge and leading edge to leading edge, everything on the aortic side, so that you had greater capture and more sensitivity of these measurements, i.e. you weren't underestimating the diameter of this measurement and missing people with aortic stenosis. So once you measure near the aortic annulus at the base of the leaflets, your left ventricular outflow tract measurement should typically be around 2 centimeters. And so you want to be measuring within 0.5 to 1 centimeters of the valve orifice. So the valve orifice, the aortic opening, it's a circular opening in front of and to the right of the left ventricular or atrioventricular orifice, and it's separated by the anterior cusp of the bicuspid valve and guarded by the aortic semilunar valve. So once we've taken the measurements of the left ventricular outflow tract, we can move to a visual inspection of the aortic valve. And similar to all the valves we'll be inspecting with ultrasound, we want to be looking for a couple of major things. So in our visual inspection of the valve, we want to see that the valves are moving apart and coming together in systole and diastole properly. And what I mean by properly is that there is symmetric motion on both sides, that the valve leaflets are coming together fully, coaptation is what it's called, of both of the cusps, so that there's not irregular blood flow from one area to another area over a valve that hasn't come together well. We want to be looking at both valves, and in this case, 3 valves, although we can't necessarily see the non-coronary cusp. But for this case, the right coronary cusp and the left coronary cusp don't have any vegetations on them. Vegetations on ultrasound look like irregular, there's an EM term, the Goomba for them, but irregularly thick projections onto a valve, an area of high echogenicity, so an area that's hyperechoic, a bright white structure that wouldn't necessarily be there or is only present on one valve cusp but not the other. So once we've assessed that the cusps are without irregularities like hyperechoic structures, and they are moving in systole and diastole symmetrically and with the other valves, and they are coming together, then we can go on to add color Doppler over both the LVOT and the aortic valve, looking for aortic regurgitation. So if the aortic cusps are not coming well together, not co-opting, then there might be abnormal blood flow moving from one area to another because the blood is able to move during both systole and diastole. So in diastole, when that valve should be closed, blood is still able to move across it. And what that looks like is a mixed picture on color Doppler. So instead of seeing a single red, a single blue, you see this mixed picture that we can see in this severe aortic regurgitation image. We can add spectral Doppler to measure for aortic stenosis. So spectral Doppler shows the blood flow measurements graphically, displaying flow velocities recorded over time, instead of displaying Doppler measurements visually as in the color Doppler and power Doppler modes. And then finally, you can measure the diameter of the aortic annulus. And this image on here on the bottom has our tips that we used in the last slide. Here is a parasternal long axis view of the aortic valve. So in this first one, we see normal movement without restriction of, we can pull in right here, of this aortic valve. The second one, we see a heavily calcified, so hyperechoic, very bright white aortic valve leaflets, and there's restriction to flow on systole. So as the heart's trying to contract, you're not seeing that symmetric and powerful opening of the aortic valve cusps. They're heavily calcified, where we can see this bright white area, whereas we don't see that on these two cusps, on the right and left aortic cusps. So once we have looked at the aortic valve, we can start moving down the line to the aorta. So we want to be visually assessing the valve. So there's a couple of different parts that we're going to be going through as we visually assess the aortic valve. Starting with A, B, C, D here in the bottom left, we start with the aortic annulus, then go to the sinus of Valsalva, the sinotubular junction, and the ascending aorta. I think that it's important to note each of these different sections, but it might not necessarily be on your radar to be taking measurements at all of them. If we're looking for something like an aortic aneurysm, which is a dilation of the aortic root, the ultrasound image could be showing an intimal flap. So an intimal flap consists of a dissected aortic intima, which is separated from the aortic wall. This intimal flap separates the aortic lumen into a true lumen, and that's a lumen where blood is flowing, so a passageway that blood flows, and a false lumen, aka like a hematoma, where blood is going to be stored. So what we can end up doing is looking with color spectral Doppler to determine the flow signals. So if you have a false lumen and a true lumen, one where blood is in stasis, not necessarily starting to coagulate, but not flowing, and then a true lumen where blood is flowing, we can use pulsations of blood and movement of blood under an ultrasound transducer to determine if there is blood flow or if there is not. And that can help us look at a intimal flap. So we're looking for aortic aneurysm here. You can take measurements of the linear segments of the aorta. And in image A, we have that. So you'll be taking your aortic valve diameter, sinus valsalva diameter, sinotubular junction diameter, and ascending aorta diameter. And these are going from lumen to lumen, as we kind of talked about in our previous slides, where past the aorta is lumen to lumen. And then here's a cutoff value. So in men, say like you're looking at the sinus of valsalva, that should be greater than, or shouldn't be greater than 4 centimeters. Moving on, we have the plaques view of the left atrium. So left atrium, we're really looking at the size of the left atrium. And that size should range from 1.8 to 4.0 centimeters. We're looking at the anterior posterior diameter. And we can see it here on this right image. So we're going from that point of Valsalva, or the sinus of Valsalva, where we just took a measurement on the aortic measurements slide, and we're going perpendicular to the plane of the left atrium. So we're going to measure an end systole, and hopefully this shouldn't be affected by artifact, but down here you can see there's a little bit of noise going on. Moving on to the left ventricle. So we start with a visual assessment. So again, the left ventricle is one of the main chambers that we're focusing on. It's the heart's main pumping chamber. It pumps the oxygen-rich blood into the body's main artery called the aorta. Obviously, it's implicated in heart failure, and we'll get to that when we start talking about ejection fraction, which is your heart's ability to pump the oxygen-rich blood out toward your body. But in our first visual assessment, we want to look at the basal and midventricular septal portions. We're observing if the walls of the left ventricle, are they pulling in evenly? So from outside pericardium, this white bright structure, is this external wall pulling in evenly with the interventricular septum? Are they pulling in too much, not enough? Is one side pulling in more than the other? And then we're looking at mitral valve function. How does it close? How close does it come to the interventricular septum? And the closer it comes, the better. We can use that, and we'll start talking about estimations of ejection fraction just by eyeballing that mitral valve and how well it's co-opting, and then how well it's slapping against that interventricular septum and the septal wall. We're going to assess wall motion during systole. So all myocardium should thicken on systole as the heart's trying to squeeze out all of that blood and travel toward or travel away from each other during diastole. Then we can measure the diameter at end systole and end diastole and compare to how to come up with an estimation of the size of the left ventricle. And then color Doppler may occasionally detect a VSD, showing blood flow from the left ventricle to the right ventricle or right ventricle to the left ventricle. So moving on, so from this parasternal long axis view of the left ventricle, I've put up a couple of scene clips, and these scene clips are our way of doing a quick qualitative approach to estimating ejection fraction. So this is the quick and dirty way of eyeballing, is this patient in severe heart failure, HFrEF, HFpEF, or do they have hyperdynamic heart function? And hyperdynamic heart function, seen up in the top left corner up here, is mostly due to decreased preload, right? So you have cases of hypovolemia, catecholamine surges, underlying conditions like hypertension, sepsis, or changes in cardiac function reduce that preload, needing the heart to work faster. So we're visually assessing the basal and midventricular and septal portions, right? We're observing how well the walls are pulling in from the left ventricle. Are the walls pulling in evenly from the external part of the left ventricle to the interventricular septum? Are they pulling in too much, not enough? And then we're observing the mitral valve. how well are the valve cusps co-opting, and how well are they slapping against the interventricular septum and the septal wall. So in normal ejection fraction, 55 to 69, 70%, we can see that the mitral valve leaflets are co-opting well together. Obviously, we don't have color Doppler over, so we can't see if there is some sort of regurgitation. But we're also seeing that they're slapping against the interventricular septum and the septal wall very well. We're looking at the ventricular wall motion. So at the interventricular septum and the ventricular wall, they're coming together well in systole and pushing out well in diastole. Same thing with the bit of the right ventricle that we can see there. We're also looking to see that there is no stasis of one part of the wall. The walls are moving symmetrically and all together. As we move on to mildly reduced ejection fraction and moderately reduced ejection fraction, I think this is a good example where we can see that the cusps of the mitral valve don't seem to be slapping as vigorously, for lack of a better term. And then we're also seeing reduced contraction of that right ventricle, and we can't see all of the left ventricle, but it looks like there is some reduced contraction of the left ventricle, both at the ventricular wall and interventricular septum. And finally, going on to a severe ejection, severely reduced ejection fraction, under 30%. There's almost no movement outwardly of those mitral valves, so to come closer to that interventricular septum, which I think is an easier way to see it than at the ventricular wall. And it almost looks like fibrillation. It's not quite, the left ventricle's trying to move closer and together on systole, but you can see that there's almost no movement. So there's almost no ejection of blood out of the left ventricular outflow tract to the aorta. So we can see here. Same with the right ventricle here. So this interventricular septum's pretty static, and there's no movement inwardly of that ventricular wall. So we've taken our eyeball measurement. We've seen if the heart is hyperdynamic, if it's moving very, very quickly. We've seen if there is reduced ejection fraction qualitatively. We've looked at the mitral valve slapping. We've looked at the movement of both ventricles in proportionately and symmetrically with vigor or without. But now we want a qualitative measurement of ejection fraction. And so we can use a couple of different options. So we can use fractional shortening, fractional area change, or endpoint septal separation, and those are what I'll talk about. There's a couple other methods, but those are the three that I'm highlighting. I think something we'll talk about, endpoint septal separation, is the easiest to find, and probably on a point-of-care bedside ultrasound, that's the one I'm using the most. But looking at fractal shortening or fractional shortening, it's the proportional difference between a linear dimension of the left ventricle in systole and diastole. So right under the first sentence is an equation that we'll be using. In reality, the ultrasound machine is going to be using it when we take these two measurements with our calipers. This is the equation that it's going to be putting those two measurements in to find the fractional shortening. So we have fractional shortening is equal to the left ventricular internal diastolic diameter minus the left ventricular internal systolic diameter divided by left ventricular internal diastolic diameter times 100. So how we're going to find this view is we're going to be in the parasternal long axis view, selecting M mode and placing the cursor in the middle of the left ventricle, being careful not to include the mitral valve or the papillary muscle. We're going to be freezing this in an M mode image, so M for motion, looking at the motion capture under the ultrasound transducer where things are moving, and then measuring the left ventricular end diastolic diameter and the left ventricular end systolic diameter. And you can think about this just as if you have a container and you want to see how much is actually in the container after you squeeze it, like a water bottle, you're going to measure the amount of volume or the space taken up by that container before you've squeezed it, and then after you've squeezed it. And that'll show you how much you've actually squeezed out, in the same way that measuring how big the heart is at the end of diastole and then how much smaller it gets at the end of systole can tell us how much fluid has actually moved out of that heart. So that'll give you an ejection fraction reading. Once you put it into the ultrasound machine, it should give you that same thing. But we have this equation here so that we could do it on our own. So in that parasternal long axis view, lining up in the center of the left ventricle, making sure not to include those leaflets or the muscles at the inferior aspect of that heart, taking a motion capture or motion mode scene clip, and then taking your calipers and putting it onto that ventricle at the end of diastole and end of systole. So in a male, a normal ejection fraction would be about 25 to 43% change or fractional shortening of that diameter or that area that you've taken. And here's a chart with some descriptions of normal and abnormal. So the next way that we can estimate ejection fraction is pretty similar. So instead of taking shortening of two walls, we're going to take the overall area change of the left ventricle. So I think that this image here on the right has a very intuitive way of thinking about changing the area volume and measuring the size of that container, the left ventricle, while it's being filled and then while it's squeezing out. So we compare the area of the left ventricle when viewing the mitral valve function in the parasternal short axis view during systole and diastole. So, right, we'll be changing to parasternal short axis for this, looking at a cross section of that left ventricle. We'll be at the level of the papillary muscles, taking a measurement at the end of diastole, which will be the maximum area of fluid, the end of filling, and then comparing that to the end of systole, the minimum area of fluid inside the left ventricle. And then we're inserting these values into the equation, which is over here on the right, to obtain the fractional change. So I think this one's a bit harder, just because as opposed to having a defined image of where that interventricular septum and the ventricular wall are stopping, you are needing to look at a parasternal short axis view and not fully aware of how high or how low you should be going in terms of diameter. That's at least my take. Obviously, someone who's much more experienced with ultrasound could probably find it in both. But there are limitations in that if you do have regional wall motion dysfunctions, so think about like a prior MI where you have had ischemia to one part of the heart, and that heart has a regional wall motion abnormality, it's not going to be moving as well as the other parts of the heart, and that may result in over underestimation of global function. So for the same reason, I tend to use the EPSS or the fractional shortening if I needed to, but mostly EPSS, just because you don't necessarily know about the regional wall motion abnormalities that may exist there. Again, here's a estimation of ejection fraction based on the fractional area change. So next we'll look at probably my most used method of estimating left ventricular ejection fraction, which is the endpoint septal separation. So the endpoint septal separation is the distance between the anterior leaflet of the mitral valve and the septum, called the EPSS, which we can see right here. So it's taken when the mitral valve has reached the maximum excursion during early diastolic filling. So during diastolic filling, we want the valve to be fully open. And this value is worse if the EPSS distance is larger. So essentially what that's saying is the mitral valve isn't making its way all the way to the interventricular septum. In a heart with reduced ejection fraction, as we were seeing on that quick eyeballing method for estimating left ventricular ejection fraction, the mitral valve wasn't slapping against the interventricular septum if you have an ejection fraction of, say, like 30 or 40. So how do we take this? The most crucial step in obtaining is getting a good parasternal long axis view. You want to really be able to see both of those mitral valve leaflets and a horizontally oriented left ventricle. You place the M-mode cursor over the tip of the mitral valve as the anterior leaflets travel toward the left ventricular septum, and once you've captured that in a scene clip, then you can turn on M mode and measure the distance between the mitral valve, the E wave right here, and the A wave, which is the mitral valve in systole. So that symbolizes the left atrium passive filling of the left ventricle, and then active closure. So here we have measurements of estimations of left ventricular ejection fraction from the endpoint septal separation. We're using this formula 75.5 minus 2.5 times the EPSS. According to cardiac MRI data, EPSS measurements less than 8 millimeters are considered to have a normal left ventricular ejection fraction, while measurements 8 to 18 are mild to moderately reduced ejection fraction, and then over 18 is severely reduced ejection fraction. So after the EPSS is obtained, we can put it into this formula to calculate the left ventricular ejection fraction, or you could do it on your own. There's a couple of apps out there that have this formula in them. I really like this. I believe it's from POCUS 101. Just having all of these calculations lets you do it if you're in a resource-limited place where you only have a single transducer that is not hooked up to a machine with any cardiac settings. You can just use M mode, calculate those with just a caliper, and then put them into this calculation to come up with an estimation of your left ventricular ejection fraction. There are some limitations there, things that are affecting only the mitral valve, like calcifications or repair, can't then let you estimate a global cardiac function or global function of the left ventricle because that mitral valve has a problem with it. So here we have a YouTube link. I think it'd be awesome if you guys are watching this to go check out from POCUS 101. It's just an EPSS example running through step by step on an actual ultrasound machine. So if you pull this up next to your ultrasound and your patient while you're doing it, maybe not your patient, maybe someone you're practicing with, and then go into your patient, it's a great way to get those physical correlations with what you're actually doing and the material that you're learning here. So moving on to a plaques view of the right ventricular inflow tract. This isn't a view that I really get all the time, but so in the parasternal long axis, it's the only view visualizing the posterior leaflet of that tricuspid valve, and you're really assessing leaflet coaptation. And then you can, again, use color and pulse wave Doppler to examine the tricuspid valve. This little Sono snack tidbit that I found was great. It talks about why we're doing this, looking at endocarditis, looking for regurg, again, with that color Doppler or pulse wave Doppler. Is there a thrombus in the IVC, right atrium or right ventricle? And then visualizing that coronary sinus, assessing a pacemaker and an ICD wire, which there should be in the bottom right there. And then for fun, really, which ultrasound's all fun. So I think that's a good way of looking at it too. Next, what we'll be doing. Okay, so we're going to be looking at the cardiac output calculation. So you'll notice a lot of these images are really, really beautiful. They're coming from POCUS 101, which is a great resource for anything ultrasound. I used it for a lot of the material in this presentation, as well as just for a lot of my own learning throughout medical school. So thinking about cardiac output, as everyone knows, it's the basically just the amount of blood pumped by the heart in a minute, and it's how we get blood to flow around the body. So essentially the volumetric flow of the heart's pumping output, that is the volume of blood being pumped by a single ventricle of the heart per unit time. And we can use ultrasound to come up with an estimation of the cardiac output. And it just involves estimating the amount of blood, the stroke volume, that comes out of left ventricle at the left ventricular outflow tract. And we take two measurements. POCUS 101 has an awesome calculator if your ultrasound device doesn't have cardiac calculations built in when you're using your caliper to measure things. It's linked in my PowerPoint presentation, but you can just Google POCUS 101 cardiac output stroke volume calculator and you'll find it. We're going to go through the actual kind of math behind it, which is pretty basic, but bring back the idea of integrals, which for many people in medicine we haven't thought of in a long time. So we use two measurements, the left ventricular outflow tract area, and then a velocity time integral. So essentially how fast something is moving under a certain or in a certain amount of time, and that's where an integral comes into play. So you're looking at time under under a curve. So if you think of the left ventricular outflow tract as a cylinder, which is illustrated in this nice image right here, we're measuring the amount of fluid coming out of that left ventricle over a certain amount of time to estimate the stroke volume. Once we get all of these measurements, then we can put it into this equation, which I think is a super handy pocket card. So this is our cylinder. So pi r squared sounds like area to me. The rhyme doesn't work as well with a cylinder, but essentially it's pi times diameter over 2, which would be the radius squared, times your height. For stroke volume calculations, we're going to use the same concept, the idea of area in a cylinder and then movement of a fluid under a graph of time. So we're taking the left ventricular outflow tract diameter, seen on the bottom here, and then plotting it against the velocity time integral. And then you can simply calculate it based on the formula. So going through these calculations in a stepwise fashion, I really like to have that cardiac output card from POCUS 101 next to me while I'm doing this. If I'm doing it on, say, like my B-scan that doesn't have the calculations or cardiac mode with me, or I'm doing it on another tool that doesn't. So first thing we're going to do is identify the parasternal long axis view of the left ventricular outflow tract. We've already been here. We've taken a bunch of these measurements already. So we're freezing the screen, then we're measuring the left ventricular outflow tract 0.5 to 1 centimeter from the valve orifice, which you already knew, and measuring at mid-systole. So if you're not using a machine with the function, then you can put that measurement into this equation that we have down here, and that's also on that card. Once we've done that, we're going to flip from a parasternal long axis view looking at the LVOT to a apical 5-chamber view. And in understanding the apical 5-chamber, we want to know that we can see the left ventricle, right ventricle, obviously right and left atria, and then that aorta. And that aorta is where we're actually going to be taking this measurement from. So we've identified the left ventricular outflow tract and the aortic valve. This is a beautiful apical 5-chamber view. We're going to take our pulse wave Doppler, which is going to show us a visual representation of the flow under that transducer, and then ensure that the gates are parallel and place that pulse wave Doppler gate at the aortic annulus, so the base of the aortic leaflets, and you can see that right here. So we can see these aortic leaflets opening up right here in this 5-chamber view, and that's where we want to position our pulse wave Doppler gates. Once you've placed your pulse wave Doppler gates, then we're going to be identifying the velocity time integral. So going back to calculus, whenever you took it, integral, right, is area under the curve. So we're going to be using the pulse wave Doppler to take an image of the amount of fluid moving under the transducer under a certain period of time. So we've identified our landmarks with the gate in place. We're activating the pulse wave Doppler. Then you're going to freeze and calculate the LVOT velocity time integral. What we mean by that is here's our tracing from our pulse wave Doppler. This creates our curve, the outline in yellow, and then the area under the curve, tracking our velocity time integral, is this area within that yellow outline tracing. So a normal left ventricular outflow tract velocity time integral is around 20 centimeters. So that's calculated by assuming a normal stroke volume is 60 milliliters and an average left ventricular outflow tract diameter is 2 centimeters. And if you use the cylinder formula to about calculate that, a normal LVOT comes out to just about 20 centimeters. So once we've gotten left ventricular outflow area and the stroke volume, we can put them into the last step, step 3 of our stepwise process to actually get the cardiac output. Your machine might be doing this for you, but fortunately we have our little pocket card with all of these calculations on them so that we can do them ourselves. Phew. Okay, so we are done with the parasternal long axis views, and that took a ton, right? So there are a lot of things that we want to see there and a lot of calculations we're doing. Now we're going to move to our PSACs, the parasternal short axis views. So we're starting in a short axis, looking at the heart from inferior to superior, and this involves tilting and sliding of the probe. Sometimes these views can be tough to understand truly where you are, so I think I like to use landmarks of whether you're at the valve, whether you're at like mitral or aortic, or whether you are in the mid region of the ventricle or down at the papillary muscles, which can look like more hyperechoic and just larger or denser structures. So practice these a bunch. Getting to know where exactly you are from inferior to superior on the heart is a skill without a valve, and go from there. So we're going to look at the aortic plane, the mitral plane, papillary muscle plane, apical region. So starting with the mid-papillary view, we're trying to get information regarding the overall ejection fraction. How well are the valves coming together and opening back up? Looking at the right ventricle for any sort of dysfunction. Is that right ventricle bowing into the left ventricle at the intraventricular septum? Is there a lack of systolic motion with the right ventricle? And then same with the left ventricle. Do you see regional wall motion abnormalities? And what I mean by regional wall motion abnormalities, say we're looking at this entire left ventricle, is one part of the left ventricle here, moving differently than the other parts of the left ventricle. And that's important because that could indicate ischemia or some other abnormality to one specific part of the heart. Think about looking at EKGs, which we'll talk about, and how those can correlate to what you're actually seeing on ultrasound. You can infarct one specific part of the heart while having normal function in the rest of it. So the structures that we're looking to identify at the PSAS mid-papillary level are the right ventricle, left ventricle, and papillary muscles, these little Goombas kind of hanging out down there. We're also looking at the wall motion, and we're not using Doppler to assess anything here because there's no valve, right, that we're looking at. Moving on to the mitral valve view. This is colloquially called the fish mouth view because you see a fish mouth opening and closing. We're looking to identify the right ventricle, left ventricle, anterior and posterior leaflets of that mitral valve right here. Overall, the right ventricle should be a third of the size of the left ventricle. If we have changing of that, then that can be pathologic, right? So we have a buildup of, say, like pulmonary pressure if you're getting the right ventricle starting to bow out into the left ventricle, or you're getting a larger right ventricle because there might be something like a pulmonary embolism. So again, you're assessing left ventricular wall motion. Everything should thicken on systole and everything should thin on diastole. And then you also assess leaflet coaptation. So the mitral valve leaflet should be coming fully together and then moving fully apart. When you put color Doppler on this, you should be seeing a lack of color during systole. So once everything is squeezing, the mitral valve leaflet should be completely closed so that you're not getting regurgitation from the left ventricle into the left atrium. And in that, there should be no color on color Doppler. And we're not using spectral Doppler here. Moving on to the aortic view, this is traditionally called the Mercedes-Benz view. It's called the Mercedes-Benz view because we're making that Mercedes-Benz sign right here. That's showing us that we do have 3 leaflets. So we have the right coronary cusp, the left coronary cusp, and the non-coronary cusp. So in here, we can kind of see the right coronary cusp, and then we're seeing the non-coronary cusp down here, and then the left coronary cusp. We want to see that those are all coming together as well. In the same way that we were looking at the mitral valve, we can put on color Doppler here to assess for coaptation abnormalities where there's blood flow in systole or diastole where there shouldn't be. You can look at the right ventricular outflow tract with Doppler to see a similar thing. And then advanced evaluations that we're not going to talk about here are bicuspid aortic valve. So if you're only seeing 2 cusps there, is that a congenital anomaly? Grading of aortic stenosis, so severity of it, is a whole other set of calculations that we won't be going over. Tricuspid regurg, and then calculating pulmonary pressures here. Moving on, we have the apex. So this is just looking at myocardial motioning and thickening are assessed. There's not a ton here, and it's I would say mostly covered when you're looking at the bulk, like the papillary levels of the left ventricle. It's something to note as well. So moving on to our apical views, the 4-chamber view. is the most widely used screening tool to detect structural cardiac abnormalities during routine fetal ultrasonography. So looking on adults, we're getting a lot of our images from maybe our parasternal long view, our apical 5-chamber view, but in looking for fetal abnormalities, we'll be using the apical 5-chamber view. Not saying we, but someone would be using apical 4-chamber view. So in a perfectly aligned 4-chamber view, the ventricle or the ventricular and atrial septum should be straight down, like you see right here. That means that the 4-chamber view should be vertical. However, clockwise rotation is often seen in people who are just starting to get these apical 4-chamber views. So this is the view that we're going for. You can see cardiac abnormalities here. If you were looking for, say, a VSD, ASD, you could put on color Doppler and try and see if there's flow between the ventricles or the atria. That shouldn't be there. At the apical 4-chamber view, we can go to the left ventricle. We're going to visually assess for myocardial thickness, wall motion, and then ejection fraction. We move up to the mitral valve. We're going to be assessing for mobility, structure, diameter, coaptation of those valves, similar to how we were assessing in the left ventricular or parasternal long axis view. We can place color Doppler over the mitral valve and start to see if we're getting the mixing of the colors, the mixing of the red or blue, which, remember, are flow moving toward or away from the transducer, not venous or arterial, as we often teach kind of new learners to ultrasound. So again, in the case of mitral regurg, continuous wave Doppler can be placed at the vena contracta. Again, you can see here that the ventricular and atrial septums are straight down, which is how we want to set up our exam. So in evaluating diastolic dysfunction, we're going to talk a little bit about the E to A ratio, but this is using spectral Doppler to reveal a biphasic flow. So the first wave, or first phase, denoted with the letter E, represents the passive emptying of the atrium, and the second phase, A, represents atrial contraction. And so we can take a look at the ratio between the emptying of the atrium and atrial contraction to evaluate ventricular relaxation, otherwise known as compliance. The less compliant the left ventricle is, then the larger A becomes, such that the E to A ratio is increased in some situations. This is somewhat out of the scope of this lecture, but I think that it's important to know that there are additional measurements for each of these valves, for each of the flow rates, so that we can evaluate diastolic, systolic dysfunction, or global heart function. So now we're going to be looking at MAPC and TAPC. MAPC is the mitral and TAPC is the tricuspid annular-plane systolic excursion. So these are measurements that add valuable information to the function of the right and the left heart, and they highlight abnormalities that you might not see when you're just evaluating ejection fraction, and the ejection fraction is normal. So MAPC uses M mode to assess the left ventricular systolic longitudinal function, so moving in a z-axis. It's a quick way to evaluate the left ventricle from an apical cardiac window, and it's useful because decreased excursion or movement of the mitral valve during systole correlates to left ventricular systolic dysfunction. This can actually precede changes in the left ventricular ejection fraction, so coming before you're seeing a change on like EPSS during an MI. So lower MAPC can indicate systolic dysfunction overall. So how we're going to do this is to get a apical 4-chamber view and then focus that on the mitral valve. Once we've focused it on the mitral valve in that apical 4-chamber with the ventricular and atrial septums perpendicular to the ground in a horizontal or a parallel plane, we move the cursor over to the lateral aspect of the mitral annulus and then freeze image, and then we can measure the trough and peak. So the end of diastole and the end of systole, where that mitral annulus actually is. And taking that measurement, we can evaluate whether it's low of normal or at normal. Normal in the cardiology literature has been shown to be like 12 to 15 millimeters of excursion, so the difference in the systolic and diastolic location. And It's important to know that these values can be affected by local wall motion abnormalities that can affect the myocardium near the mitral valve, mitral annular calcification, or mitral valve prosthesis. So in the same way that in the parasternal long axis view, we had to know about mitral pathologic processes going on so that we could not generalize mitral function to global cardiac function or to left ventricular function. We have to know that here as well. Here's a video that shows everyone how to do it from the Echo Lady. It's an awesome video. It goes through all of the Echo steps, and I think everyone should check it out after this. So moving on to our tricuspid valve and the apical four-chamber view, we're assessing again for mobility, structure, how well the valve is coming together, palpitation, and we can put color Doppler over it to see presence of regurgitation or stenosis, and then we can measure the tricuspid annulus. Here you can see severe aortic regurg with color Doppler, so you're getting that mixing of color as you're going into systole there. Moving to the right ventricle, we're assessing for myocardial motion and thickening. We'll be looking at right ventricular size and strain. So what we don't want to be seeing is right ventricle greater than that 1/3 to 2/3 ratio that we saw of right ventricle to left ventricle, which could indicate some sort of hypertension, like pulmonary hypertension, a PE, pulmonary stenosis, things like that. Down in the bottom right, you can see typical measurements for right ventricular size. In the top right, this is where you would take those measurements. You take one parallel and then two perpendicular to the right ventricle. So I thought this was just interesting. This was a case that one of my colleagues had seen early on in medical school, the Epstein anomaly. So congenital heart defect, looking at right ventricular size. So the valve, tricuspid valve, is not forming as it should, and it's located lower than it is in a usual heart. Can occur between there's a hole, or when there's a hole between the two upper chambers of the heart, like ASD, classically taught, caused by lithium in pregnancy. But this is something where a measurement of the right ventricle would show that it's much smaller, and then a measurement of the right atrium would show that it's obviously much larger. So just an interesting clinical application of the case. Moving on, right ventricle is a great place to start talking about our PE diagnoses. I thought this was a really awesome way of looking at PE as an algorithmic evaluation of the patient as a whole, and then evaluating them with ultrasound. I think classically everyone's taught like D sign and McConnell sign to start thinking about PE. But jumping through this, so if a patient's coming in with their unexplained chest pain, dyspnea, tachycardia, your attendings are pimping you on Wells criteria, PERC criteria, you're suspecting a PE, but CT is not feasible. Either you're in a resource-limited setting, it's not available to you right now, or you're needing to transport them, say like you're in an ambulance or working on flight or something. First thing that we're going to look at is right ventricular dilation. So any of the cardiac views, if you're seeing that the right ventricle is greater than that ratio of 1/3 to 2/3 right ventricle to left ventricle, start to become suspicious. If you see the septum start to flatten, this is called the D sign. It's mostly seen in this pulmonary embolism, and it is highly specific for it. Next, we start talking about McConnell sign, which we'll talk about a little bit next here. Then, if you're still unsure, you can evaluate the heart with TAPSE, which we'll talk a little bit about. Again, that's tricuspid annular plane systolic excursion. So it's a very, very sensitive, as opposed to a specific signal for acute pulmonary embolism. And then finally, tricuspid valve regurgitation, so seen in that apical four-chamber view. Again, all of these are if this is your resource and maybe you don't have a CT there, or you just have ultrasound at the bedside and you'd like to get more confirmation of something before going to CT and additional intervention. So McConnell sign. So it's defined as right ventricular free wall akinesia, so it's the lack of movement with sparing of the apex. They talk about it as the trampoline sign, so you end up seeing a trampoline bouncing up and down here, where you have this right ventricle lacking in motion, so that akinesia and trampoline up there. It's not sensitive, but there was a small study that said that it was specific for acute PE, and it's a very distinct find. finding. So if you see this on one of your patients with shortness of breath, start to think PE. Moving on, D sign. This is that bowing or septal flattening in the parasternal short axis. It's right ventricular overload causing a shift in the septum toward the left side of the heart. If you've learned this in, say, your FAST, your rush exam, and you want a little bit more, I thought the eccentricity index described by Ryan et al. Was really interesting. So it's an echo measurement of the left ventricle that can actually quantify the amount of right ventricular strain and overload affecting the left ventricle. So it's calculated by taking two measurements at the left ventricular cavity. So it's a perpendicular and a parallel measurement, and then you start to compare them. And based on the amount of pressure overload, you'll get this ratio of like the parallel to the perpendicular measurements as less than or equal to or greater 1. So moving on to TAPSE, that's our tricuspid annular plane systolic excursion. This was the most sensitive method of determining if someone had a PE outside of obviously the CT. But so it's a measurement, distance measurement from the minimum to the maximum excursion, so systole to diastole of the tricuspid valve. So we're aligning our M-mode cursor parallel to the motion of the tricuspid valve annulus, and then that annulus should be moving upward toward the apex during systole. And remember, when we're in an apical 4-chamber view where the ventricular and atrial septum are straight up and down. We're identifying the maximum systolic and diastolic excursions of that annulus motion, and then measuring leading edge to leading edge. Once we've found that with M-mode, we can place both of our cursors on it to measure the systolic excursion to the diastolic excursion, and then take that value. An abnormality should be under 17 millimeters. Remember, that's showing that like there's decreased excursion or decreased movement of that tricuspid valve, which is an indicator of poor right ventricular function. This is an awesome video from the Echo lady who has really great videos on both MAPSE and TAPSE, kind of walking through exactly how to take the measurements. And here's a quick pocket chart on how to do the TAPSE. So apical 4-chamber, M-mode, measure tricuspid excursion with your risk factors. So TAPSE is important. A couple studies have shown that it's an independent predictor of increased risk for 30-day mortality in patients with acute PE. It's also predictive for poorer perioperative outcomes. So rounding out our apical 4-chamber view, we're looking at the atrioventricular plane mobility. So this is just the movement of essentially the entire heart. So the whole AV plane should travel toward the apex, which we can see up here during systole, and during diastole, the left ventricle relaxes, the AV plane recoils back towards starting position. So you can see the entire left ventricle starts to relax and move superiorly. For the left ventricular outflow tract, we can examine for regurg with color Doppler, and velocities are quantified with spectral Doppler. I didn't include the velocity measurements here because that's a bit outside the scope. For apical 5-chamber view, we can use, so apical 5-chamber, right, has both ventricles, the atria, and then it also has the aorta, so we can see kind of that Mercedes-Benz, the 3 cusps of that aortic valve right there. We can use color Doppler in the left ventricular outflow tract, aortic valve, and proximal aorta. All of those leaflets should be co-opting so that there shouldn't be color during either systole or diastole, whichever one is relevant to that valve. So direct the Doppler toward the aortic annulus, and then place your sample proximal, 1 centimeter proximal to the annulus. You can use the continuous wave Doppler for aortic stenosis or regurg, and remember the actual evaluations of something like aortic stenosis are out of the scope of this lecture. Finally, we move on to the apical 2-chamber view. So in moving the transducer, you're starting from the apical 4-chamber view, then rotating 30 degrees counterclockwise, as shown in that kind of first figure there. The left ventricle and left atrium, as well as the mitral valve, get to be visualized. And then you can also see the left ventricle on the anterior wall and the inferior wall as well. So we can assess for leaflet coaptation again, presence of mitral regurg, which at this point we probably assess 3 or 4 times. And then you can use continuous wave Doppler to measure again. Subxiphoid view, for those of you that have done the fast view, this is awesome and included in that. I do like the parasternal long axis view. I use it in conjunction with subxiphoid view, but especially on larger patients, I think that I can get a quicker and better visualization of the heart and fluid surrounding the pericardium or within the pericardium. Again, just like in the FAST, this is mainly used for diagnosing pericardial effusions. You can detect chamber defects with this, ASD, VSD, congenital heart defects, things like that as well. Again, that'd be with like color Doppler. Moving on to inferior vena cava. So if you've done the Rush exam, this is in your high map, your heart, IVC. This would be your second step. So you evaluate for central venous pressure and fluid tolerance. So in a critical care situation, if you didn't want to bolus someone with a small amount of fluid to see if they were fluid responsive or not, or tilt them back into Trendelenburg or reverse Trendelenburg, you could assess for IVC collapsibility. So we're going to talk a little bit about the sniff test and then how this differs for spontaneously versus ventilated patients. So from the subxiphoid view, with a patient still in the supine position, you can bend their knees if you want to bring fluid back into the thoracic cavity. You want to keep the right atrium in view. So you locate the inferior vena cava with the liver on the center of the screen. So here's liver. And then you need to know that it's your IVC because you see it dumping into your right atrium here. So once the IVC is centered, you can rotate your transducer to bring your indicator toward the feet. And then you get a longitudinal view of the IVC entering into that right atrium. And I see a lot of people starting to learn about IVC and looking at the aorta. With such big vessels, you can't necessarily rely on like the compressibility. You also don't know if your image is getting both of these or if you just lost the IVC and you're replacing that in your head with the aorta. So I kind of rely on dumping into the right atrium for the inferior vena cava identification. So as we start to calculate distensibility index and collapsibility index, kind of same thing, like how far the IVC can open up or collapse down based on the amount of fluid that is in our patient. We have to look at spontaneously breathing versus ventilated patients. Obviously, if you're not wanting to do your small fluid bolus and you just want a quick bedside thing, this is a great tool. So for a spontaneously breathing patient, you can have them take in a deep breath or sniff in, and then you're going to be measuring two things: the maximum IVC diameter, which will be seen during expiration, and then the minimum IVC diameter, which will be seen during inspiration for these patients. And that's due to thoracic pressures, right? Increased thoracic pressure collapses down your inferior vena cava, and decreased thoracic pressure, intrathoracic pressure, when you breathe out, increases the size. For ventilated patients, the positive pressure from the ventilator will have the opposite effect on the IVC compared to spontaneously breathing patients. So the maximum IVC diameter will be seen during inspiration, and the minimum IVC diameter will be seen during expiration. So once you've taken your calipers and you're measuring, I like to measure right as the IVC is dumping into the the atrium, but not actually at the atrium. You put these measurements into these calculations, which I've taken from an app called Resus -US, like resuscitation ultrasound, which is an awesome tool that I use all the time still, and I used a lot when I was first learning some of these exams. So suprasternal view, this is visualizing the ascending aorta, aortic arch, and proximal parts of the descending aorta. Great to see, thinking about like dissections, aneurysms, things like that. That is kind of the end of this presentation. I hope that you enjoyed it. It was a lot of fun to make, and I think I got to learn a ton about ultrasound. If you have any questions, always feel free to shoot me an email. If you just want to talk about ultrasound in medical school, and kind of more places to go from here, I am definitely open to it. If you have any critiques, I would welcome all of these. Again, my disclaimer is that I'm a fourth-year medical student now. Came up with this just because I really wanted to. I'm a predoctoral clinical ultrasound scholar, but I think that came about mostly because me and a couple of my colleagues just love ultrasound and love learning it, hopefully at advanced levels while we're still in medical school. So I hope you enjoyed. Obviously, it's a long lecture and you can kind of bounce around. If you have any questions or want any of the slides or anything, feel free to email me. I think that'd be great. Here's some of my resources. They're all awesome. Shout out to POCUS 101 and a couple of the cardiovascular societies and the POCUS Atlas and Resusc.us. They're awesome apps, and thank you.